Okay, hello everyone. We're going to we're going to start our webinar in just a second. I'm just making sure we got everybody is able to join. We have well over 430 or 425 attendees, so I'm just going to give the system a minute to make sure everybody is in, and then we will get started with Dr. Orkin. Right. Well, the marvels of modern technology. All right. Well, good morning or good afternoon, everyone. Thank you all for joining us. I wish we were gathering under better circumstances, but I'm glad we have this opportunity to connect. I want to welcome you to this webinar on preparing homeless services for COVID-19. This is hosted by the Canadian Alliance to End Homelessness. I'm Tim Richter. I'm the president of the Canadian Alliance to End Homelessness and the Canadian Network for the Health and Housing of People Experiencing Homelessness. And Dr. Orkin is a member of CNH3. So the webinar today is going to be pretty informal. We're going to have a brief discussion or a discussion from Aaron to go over a number of things related to responding to COVID-19. We're going to open it up to conversation or discussion. Now, there are an awful lot of people on this call, so we're not going to be able to do it in kind of a live fashion, but what we'll do is have everybody type in their questions. You'll see on your control panel, there is a Q&A button. That's where you can submit your questions in writing, and we will respond to as many of them as we possibly can on this call. But knowing that there's so many people and there's going to be an awful lot of questions, we may not get to everyone. So let you know that there is another call exactly like this one next week, which we may be updating a bit for evolving circumstances, but we'll have another call this time next week, next Wednesday. We're also going to develop a Q&A document or an FAQ document, and I'm just going to show you quickly well, I'll show it to you later. There is a website for the CNH3, the Canadian Network for Health and Housing of People Experiencing Homelessness. It's cnh3.ca, and on that website we have a resources section. There's a document or two that Aaron will be talking about today. You can find those there. We're posting resources for responding to COVID-19 on that site. We'll post a recording of this webinar on that site, as well as be developing an FAQ. So without further ado, I'm going to introduce Dr. Orkin. He is, well, an overachiever to say the least, but his bio says he is an emergency family and public health physician, studied medicine at McMaster University, completed a postgraduate training in family medicine at the Northern Ontario School of Medicine and Public Health and preventative medicine at the University of Toronto. He holds graduate degrees in history and philosophy of medicine from the University of Oxford and public health from the University of Toronto, and is a doctoral candidate in clinical epidemiology at the University of Toronto. His research focuses on strategies to involve the public in the delivery of essential health services in low-resource settings and vulnerable populations. His work explores the intersection between public health and clinical medicine, works with an emphasis on health system design and health equity. He practices emergency medicine at St. Joseph's Health Centre and Humber River Hospital, and he is also with Inner City Health Associates. And so without further ado, I will pass it over to Dr. Orkin. Thank you, Dr. Orkin.
Hello, everybody. Please send a note if for some reason the audio isn't working for you, or if we can improve any of the technical aspects. Folks, I am really honored to connect with you. And I've never even conceived of a webinar with this sort of response. I imagine that there more than one person in some of the rooms and some of the logins, so that this number that I'm seeing of 270 participants is probably itself an underestimate. There is only one reason why that sort of thing would happen, which is that we are facing a crisis across the health system related to the COVID-19 pandemic. And for really all of the reasons that drive our work on a day-to-day basis, even when there is not a pandemic, that will very rapidly manifest itself as a serious calamity among people who experience homelessness and among the communities that we serve. What is so inspiring to me is two things. First, I see tremendous rising of not only a commitment and a curiosity around how to address this problem, but an extraordinary volunteerism among the people who serve these populations and in the community itself of people affected by homelessness. We have a window of opportunity to take steps to protect this extremely vulnerable community, to build on its strengths, and to respond aggressively in the next few days and weeks across our country and across our communities to blunt the impacts of this pandemic. What I want to share with you before I go into a little bit of a framework, and I hope to speak for no more than about 10 or 15 minutes about the way I'm thinking about this, this emergency, is a general high-level thought. Because some of the ideas and some of the approaches that I'm going to be suggesting are aggressive, are assertive, and are fundamentally designed to save lives. And I think that there is a risk or a possibility that some of the concepts or approaches that I might raise could even raise questions around whether or not how well they align with our normal approaches as workers and practitioners in homelessness or in health of people experiencing homelessness. And what I mean by that is that some of the approaches that I might be talking about might not always align with the philosophies that we normally use that really adhere to a shelter-first type approach to health. On a general basis, in all of our work, and I am one of the adherents to this philosophy, housing an individual, keeping them sheltered, is the number one most important thing for their health. And I am saddened to say that I believe that we are under one of the rare circumstances where we may be facing a threat that requires us to think differently about some of those concerns, and that may require us to really focus on how can we reduce COVID-related health threats, even if there are other challenges in that process. I raise that not because I like it. I raise that because I despise the circumstance that our communities live in on a day-to-day basis. The solutions to this threat and this problem are not the sort of thing that we should be faced with. We should have communities where people are housed, where there is adequate space and adequate sanitation, adequate hygiene, and adequate supports in the shelter system. And as a result, some of the most challenging parts of the approaches we may be taking to save lives in the coming days and weeks are a feature of that failure in our society. They are not the failure themselves. So let me go into some of this framework. People experiencing homelessness because of a combination of their underlying health conditions and comorbidities, to use medical language, as well as the circumstances under which they live, are at a dramatically elevated risk of death from COVID. I have tried very hard in reaching out to epidemiologists in China as well as in Italy and Singapore, as well as Washington State, to see whether anybody has any socially stratified data on people who have succumbed to COVID or information specifically about homeless populations. I have been unable to do so. But if we extrapolate from influenza, and if we extrapolate from other respiratory conditions, such as even pertussis, that where there have been outbreaks in shelters, or tuberculosis, we know that the rates of infection and the rates of adverse outcomes will be significantly higher. And by that, I don't mean or my belief is not that this is a marginal difference, but a 4, 5, even 10 times increased risk of adverse effects. In the city of Toronto, where I work with people experiencing homelessness, that means that we could see with broad infection across the shelter system, several hundred deaths if that were to occur. And so that's the background that we're up against, with a very short time window to try to figure out what will work to blunten that effect. And in thinking about outbreak management, we've really broken that into a few categories, which is testing as well as surveillance. Who should be tested? How should they be tested? And what is the purpose of that testing? The second main area is around system and policy making coordination to try to engage in the high-level talks and the high-level agreement about this population that's so desperately needed. The next category is risk stratification, and I'll leave that description there till I get back to it, because this is a novel approach that we are developing in the city of Toronto, and that I think has some application across all shelter systems in Canada or even elsewhere that might be facing this challenge. And then the last sort of category is our general approach to practices of isolation or cohorting for people experiencing homelessness, both in shelters and elsewhere within our communities. So let me start with testing. The important thing to consider around testing is not necessarily the mechanics of who should be tested with a nasal pharyngeal swab for COVID-19, but rather what is the purpose of testing? Why do we test for COVID-19? And I think it's useful for all people across the shelter sector or homelessness services sector to have some appreciation of this. Testing within the context of a widespread epidemic, there are two main reasons why we might do that. The first is for containment, which is the model that we have seen thus far and that has been practiced at a global scale, especially when we saw the tremendous efforts in China to contain and control the spread of this virus, with the hope that it could be contained within China or slowed down. Containment is about identifying every person who has a condition or who has COVID-19, with the goal to try to prevent additional transmission in any way within their community. Mitigation is a different approach, which we are already seeing and have certainly seen across jurisdictions like Italy, the United Kingdom, and really taking off across the United States as well. The approach around mitigation is to be testing individuals so that we can keep COVID out of the most high-risk settings and protect those high-risk settings so that they don't overwhelm our resources, such as hospitals. We have switched in Ontario in a very assertive way in the last 24 hours from containment to mitigation strategy. And what that means for shelters is that it is actually all the more important that we be testing people who live in congregate living settings like shelters, but that also includes other very vulnerable populations such as prisons, where an outbreak of COVID-19 in that very vulnerable population with numerous other health complexities would not only overwhelm the shelter system, but would actually overwhelm the healthcare system, which is of critical importance to the whole community. And so we've been recommending testing for COVID-19 in all people who are symptomatic, and that means that they have the symptoms of a cough, a change in their cough, a change in their shortness of breath, a measurable fever over 38 degrees Celsius, as well as living in a shelter. We have abandoned any criteria related to travel, and our goal is to identify people early within the shelter system who are affected by COVID-19. We are yet to pick up a case in the shelter system, but we hope we can pick it up early through that model. Our testing approach does add an additional layer of what we are calling Sentinel Surveillance, which is an effort to test a little bit more widely across the shelter system by reaching out to shelter staff to identify people who are having any kinds of respiratory symptoms at baseline, even if those aren't changing, and to refer them to our assessment centers here in the city of Toronto for early testing. It has been a heavy lift, but a big opportunity to engage those assessment centers to really understand the risk of homelessness and shelter housing for COVID within the shelter and for the community. And I would encourage very early partnerships between shelters, hospitals, and dedicated assessment centers to really understand and articulate the specific needs of shelters and people experiencing homelessness within testing algorithms. What I want to move on to next is this concept of risk stratification. And this is the area where I think it's important for us to really consider our goals, and for me, the goal is to take any steps necessary to blunt the impact of this condition on the shelter population. When I say risk stratification, I don't mean the risk of somebody who has become sick with COVID-19 or the severity of their symptoms or the severity of their underlying illness. What I mean instead is taking a look at the entire shelter population with the recognition that even at baseline, without a COVID-19 threat, in all cities in Canada and even outside cities, we have a tremendous shortage of shelter space, which means that people are packed in tight on cots and mats and on bunk beds in spaces that are far too condensed even without a pandemic threat. What I aim to do in that context is really to identify the people who are within that population who are at the greatest and most severe risk of really dangerous or even deadly outcomes should they become infected. We as a community of people serving those who experience homelessness spend an enormous amount of incredibly important time articulating the very complex and multifactorial health needs of the entire population experiencing homelessness. That includes issues such as addictions, mental health, trauma, and other multimorbidities. But in the face of a threat like this, we are able to identify the people who are most likely to experience harms or even deaths from this specific threat. That doesn't mean that everybody within the shelter system is at equal risk. In fact, there are people who, from a cardiorespiratory perspective, when faced with a condition like COVID, will actually do quite well. The majority of people with strong lungs and heart will have a cold or flu-like syndrome and will recover very, very well. Nestled among them, peppered within the shelter system, are a large number, though, of people who, for various reasons, in my opinion, ought to be positioned in a long-term care facility or need additional supports. They have complex respiratory problems, complex cardiac problems, and should be getting additional support. I would encourage all shelter systems to be going out into their population, identifying those people, and if I can use sort of lay parlance around this, attempting to build a moat around them. trying to bring them into spaces where there is more support. And while doing that, trying to move people who have stronger lungs, stronger hearts, who are younger, who are more well, into the parts of our system that are less well equipped to respond to this. This is the part that is most difficult, I think, for us as a community of providers to really stomach and really understand that protecting the most vulnerable, and there is a gradient of vulnerability within the population of people experiencing homelessness. Protecting the most vulnerable will also mean that some of the least vulnerable from this particular threat may need to be moved into emergency shelters, other spaces. And I cannot tell you how heartbreaking it is for me to say this, but it is even possible that some people may go more unsheltered than they would otherwise if they are well, in order to protect the most vulnerable. I want to pause there. I despise the fact that I have arrived at a place as a professional and as a physician working in the area of homelessness where I would even consider that. This is not a result of a COVID plan. This is a result of a desperately underserved underlying society that should never have arrived in this situation. And I would never advocate for people to be unsheltered or underhoused. However, we know that in our community, that is true and that is happening. And it is time for us to identify the people who are most at risk, move them into the highest service settings. And by risk, I mean cardiorespiratory risk. And to identify the people who are likely to survive this, and certainly not restrict their service, but those are the folks who should be moving into dormitory or emergency style shelters, if required, even in school gymnasia, in public settings and otherwise. But we should not be moving the people who are most at risk and most vulnerable into those open settings. It is absolutely unacceptable that we would find ourselves in this circumstance, but we must find an ability to risk stratify, to identify the people who are the highest risk and protect them. I absolutely appreciate how untenable this situation sounds, and how painful this approach is, and I raise it as a matter of urgency only. Finally, and I don't want to go on for too long, the last piece I want to raise is that I think we are all aware of how, of the instructions related to shelter, isolation, and quarantine. For reference, quarantine refers to taking people who are well and separating them from the remainder of the population to observe whether they become unwell. Isolation refers to taking people who have symptoms and are unwell and separating from the rest of the community so that they do not transmit disease. Quarantine is essentially reserved right now for people coming into the country and travelers. Isolation refers to what we might do with people who have respiratory symptoms who are in the shelter system right now. Until last week, the majority of guidance and documentation that was available for shelters was an adaptation of materials produced for long-term care facilities and retirement homes, which basically recommended that individuals who require isolation in the context of a COVID-19 pandemic should be what I call isolated in situ. That shelters should be responsible for identifying individual rooms or spaces within the shelter that can accommodate those needs. I am extremely concerned that the majority of shelters, when given the responsibility to do this, can only achieve that goal in an undignified way for the individual involved. The term self-isolation is I think an oxymoron in the space of homelessness. because this is not a decision that the individual is able to arrive at autonomously. It's very different to choosing to be in your own home or your own room. When a shelter assigns you a room and says you must stay within it, there are some coercive features to that that make me uncomfortable. I am also concerned that few shelters in Canada are equipped to do that in a way that provides the person with food, toileting, hygiene, other mental and physical health supports, as well as without achieving social isolation and everything else they need. Layered on top of that are concerns around the staff in shelters and their ability to support somebody who's in isolation. For that reason, our approach, at least in the city of Toronto, on an urgent basis, and I'm proud to say with some real success, has been to open an isolation-only shelter that is intended for this purpose. We've managed to open several dozen beds quite quickly and rooms quite quickly. I'm proud to say that we achieved that not by pushing those individuals into other parts of the shelter system or onto the street, but actually by taking the people who are already there and on an urgent basis getting them actual supportive housing, which was a success buried within this underlying tragedy. And as a result, we have a dedicated shelter for this purpose, and have had the ability from the assessment centers to move people to that shelter with additional services and some support. Inner City Health Associates is providing medical support, dedicated nursing staff, which as of today will be moving to 24 hours, as well as case management and even some peer support has all arrived at that site. It's a very small shelter, but it is growing, and we have increasing capacity as this pandemic grows. And so what does this mean for the rest of the country? I would really encourage us to consider strategies to avoid isolation in situ or makeshift isolation strategies within existing shelters, but instead identify hotel rooms, motel rooms, and other supports for people who are required to be in isolation that are truly supportive and that are a tad more dignified than cordoned off spaces within other shelters. This will evolve. The numbers of people implicated and the numbers of individuals who have active illness will grow quickly, and we will need then to move to a different form of cohorting. But again, what I turn to at that stage is a real emphasis on risk stratification. It's critical that we have some knowledge within our shelter system, if we can call it that, or within the population of people experiencing homelessness, where we can really see and really understand who is likely to have a really dangerous or even lethal outcome from COVID, and make sure that those individuals have the protections that they need. And again, I can't emphasize how challenging, but how important that is. So I'll cut off my general remarks at that stage, and Tim, maybe you can direct me on which questions to take, because they have been pouring in, and they're so good and so important, I don't even know where to start.
So there's a couple of things. I think one thing that we're seeing commonly, as a theme in some of the questions, some that we've received before and some that we're receiving now, is the challenge that shelters are having in getting some of these resources. Like, where are we going to find the space for isolation? Where are we going to find the ability to get testing? Those kinds of questions. And you had done some work earlier on a briefing note for Health Canada about why it's urgently important to get public health engaged. I think a lot of what the shelters are needing at this point are resources that have to come from public health, municipal government, provincial government, and supported by the feds. Can you talk briefly just a bit about that briefing note? And I'll put it up on the chat so that everybody can log into it if they want.
So that question is so critical, because public health right now, again, I point out that our shelter system is so deficient, and our treatment of people experiencing homelessness in Canada is so desperately deficient. Our bedfellow in that experience is public health. Public health has somewhere between 4 and 6% of Canada's entire health spending, and right now is responsible in a critical way for protecting all of us. But in a fundamental way, achieving minimum standards for isolation of an individual with a reportable disease to public health is the responsibility of public health. So their blanket messaging to the Canadian public to say, go home, here are some instructions and be safe there, is an appropriate way for them to manage that responsibility for the general public. And I actually don't hold public health solely responsible or feel that they're deficient in saying that we want every institution that is in any way able to set up isolation capacity to do so. Retirement homes, long-term care facilities, prisons, they need everybody at any institutional level to think about that. What that also means is that places that are fundamentally unable to do it to a minimum acceptable standard, and that includes for the individual involved as well as for the occupational health of those serving them and others who live there, need to reach out to public health and say, we've got a person or a population that we cannot isolate in a minimally dignified or acceptable way. And it is public health's duty to respond on that front. We have numerous examples from SARS, from tuberculosis cases, from pertussis outbreaks and otherwise, where public health in many jurisdictions across the country has responded by doing everything from renting hotel and motel rooms for individuals right through to commandeering entire hotels for this purpose. They have that power under their under their legislative authority in virtually every jurisdiction in Canada. And so shelters have received the right message. I don't blame public health for sending the message to shelters saying, figure out how we're going to isolate people. You have a week. That's really what's happened here. And that still means that if shelters respond with, we're trying, but we have an individual here and it doesn't meet a minimum standard, public health must work with you on that and has both powers and resources to do it. It doesn't fall solely on the shelter system.
But the challenge we face right now, it seems that Health Canada has basically given the direction that the shelters need to do these things, but has not necessarily directed public health in the provinces and cities to respond in that fashion. So that's one of the areas that CNH3 and the Alliance have been really pushing hard on. We're hoping for a decision that's favorable and direction that's favorable, but we haven't got it yet. And that's the key to, I think, a lot of the questions, a lot of the frustration, a lot of the stress that the shelters are feeling is that they're on their own. Places like Toronto, I think maybe Hamilton and are getting some support from public health, but that's been sort of place to place. So yeah, just so you know, we've raised this at the highest level of the federal government. We've been in contact with different public health forums. We're doing our best to get that going. I'm hopeful that it's coming soon, but as yet I can't say anything definitive. And I think that's at the heart of a number of the questions that we're seeing.
What I want to share with the group is strategic language for engaging with your public health units on that. Identifying that this is challenging, identifying that this is difficult for staff, identifying that there are resource shortages does not necessarily trigger the elements of public health regulations that really compel a local public health unit to jump in. If you're reaching out to your public health units and you're facing genuine troubles around delivering appropriate isolation in shelters, the language that we found successful in Toronto and that has carried us through in this work up to the federal level is really to indicate that we cannot achieve the minimum standards required for isolation. And so the instructions make sense. The requirement to keep somebody separated, make sure that they have food, access to a toilet that others don't use, make sure that there's adequate PPE for the staff and that they know how to use it, don and doff it appropriately, and that the person receives appropriate health care behind all of that, that all makes sense on paper. What's required is for a shelter to write back to their public health unit and say, here's the effort we've put into implementing it, and for the following reasons, it doesn't meet a minimum standard for isolation in Canada. That will compel a public health unit to respond.
So that is a very, very good tip, because I think we're pushing at a federal level for that direction, but communicating with your public health in that fashion, I think, would be helpful as well. So a couple of other questions. Here's one from Heather Johnson, saying that her estimate is at least 50% of clients have a cough at any time. How do we distinguish which cases are potential cases of COVID-19 and need testing? And related to that, there's two other questions that I'll pass along. One is, any strategies to suggest to convince our participants to get tested? The majority are very wary of mainstream health, and many may refuse to use them. And then, what measures should we be taking to protect staff, both physically from the virus, but also to prepare psychologically for the potential losses within our community?
I'm going to start with the last question because I sometimes have difficulty putting them all together. What should we be doing? And I'll ask you to come back to the one before it. Staff safety is critical, and I have to say, because I'm focused on the idea that we're going into a condition with somewhere between 30 and 70% what we call attack rate, which means the percentage of the community that gets the condition. Our shelter workers for our client population are both their greatest support, and also protecting those shelter workers is important for the health of the people in the shelters. So we are all such incredible volunteers, and I see the names of the people putting up these questions. These are the heroes of homeless service in Canada. I can't tell you how honored I am to connect with the people on here. These are volunteers that I worry about, because I know that these individuals, even without PPE, without protection for themselves, will show up come hell or high water to the shelters and the facilities to serve the clients in need. And we need to remember that protecting ourselves is about protecting our clients under this sort of circumstance. And so inadequate supply of PPE, inadequate knowledge about how to use it, using that same language needs to be communicated to the public health unit, not as a matter of charity or public outreach, not as a matter of this is a challenge that we're facing right now, but as a matter of minimum standards. We are unable to support a minimum standard right now, and there is an impending calamity. We need PPE critically. Every province in Canada right now, feeding through their local public health units or their health authorities, if you live in a province where that's the structure, has a centralized supply management of PPE, and is quite appropriately giving it out based on need and urgency. Sometimes the shelter system fails to communicate using language that triggers that urgency, while hospitals and emergency departments are more effective at it. We need PPE for our shelter workers because it's the only way to protect those shelter workers, which is in turn the only way to protect our clients. And I would, again, this is a point of real sadness and tragedy for me. I would not encourage people, for the health of their own clients, to be willing to go to work without appropriate protections. Often we work under suboptimal circumstances, and because housing and support is the most important thing for people's health virtually all of the time, we think that that translates to now, and it just might not.
The second question was, any strategies to suggest to convince participants to get tested, knowing that some will be wary of mainstream health services?
Yeah. That's where some of the Sentinel surveillance is important. So bringing testing into the facility, it is a very simple test. In most jurisdictions, nurses are doing this, and it can be taught to a lay health worker in about 30 seconds. And so that's one strategy, bring the testing to the public. The other really critical strategy is engaging peer workers and engaging people who have the most trusting relationships to see this as an outreach responsibility. We can and we should be really coaching people and taking people together to testing facilities as needed. That re-emphasizes how important it is that we have enough masks and so forth for our staff to really walk with somebody to the assessment center. At the same time, we should be aware that we're entering, there is little question that this is going to move through our population. I do not believe that we're going to keep this out of the shelters. And so the utility of the assessment centers and testing has moved from containment to mitigation. And so we need to be taking people to hospitals and testing facilities because we think that they need access to healthcare to support their illness, not necessarily purely because we believe that we want to know if they have COVID-19. And that will be, follow the instructions of your public health unit, but that will be the transition we see in the next week, that we need to be thinking about, is this person sick and they need a doctor to help them with their breathing and their recovery, as opposed to, am I curious if this person has COVID-19?
Great. So another question from Danny Bratton. Apologies if I mispronounce your name. We have a drop-in center for the homeless at our site that offers shelters. Given the importance of hygiene and cleanliness during such an event, what are your thoughts regarding street entrenched people accessing shower facilities during the COVID-19 outbreak?
So you actually cut out there in the middle. Can you repeat that last phrase?
We have this is from Danny Bratton. He says, we have a drop-in center for the homeless at our site, offers showers. Given the importance of hygiene during and cleanliness, what are your thoughts regarding street entrenched people accessing the shower facilities during COVID-19 outbreak?
It is very hard for me to weigh the risks and benefits of the two different pieces of that choice. On the one hand, if people are denied access, or if the facility is closed on the principle that the facility might not be able to operate the necessary screening or testing or protections for staff if it's a drop-in or otherwise, that may be something that is necessary for health. On the other hand, not being able to have a shower might be worse for this outbreak, and it is tremendously difficult for me to weigh which one is which there without seeing the actual facility and the dynamics, how those showers are cleaned, and how the individuals get from the street to the shower. But here's the part that I would layer on there is most important from a health protection perspective, which is really what we're trying to achieve for the population and the people that we care about so much. Among the people who are on the street, who are accessing those showers, there is a mixture. And we're so attuned as providers to have communicated that they're all high risk, and they are, I know that. But there are some who have serious cardiorespiratory problems, and others who have other health problems but may not have such severe cardiorespiratory problems. And when I hear about a space like that, what I start to wonder is there a different approach we could take? Could we say that we're going to try to pick out some of the individuals who are most at risk and use this facility to protect them right now, while accepting that some of the people who have lesser risks might not be able to access that service right now because their health threat is not COVID-19? And that's the strategy. That's the kind of thinking I really want to encourage system-wide, is rather than thinking about large groups, trying to think about who out there is likely to succumb to COVID-19 and can I build a moat around them?
Mm-hmm. Okay. Do you have a question from Deborah Gardner? Where will a person who is waiting for a test result go if they can't return to shelter?
It's a very good question. That changes from city to city and jurisdiction to jurisdiction. In Toronto, what we've set up is the isolation shelter for that purpose. And again, this is the strangeness of public health language. Isolation shelter would sound horrible under any other circumstance, but that's not what's intended here. In other jurisdictions where such a thing has not been set up, it really falls on that assessment of, can we achieve a minimum dignified standard of isolation within existing shelters. If such a space exists, I know that some communities have shelters with more of a medical design to the facility than other communities, and those are the individuals who might use those spaces. Motel style rooms are excellent with a door that goes outside. It's optimal for that sort of thing, and working with public health to say we need access to some of those kinds of rooms for that is a great idea. And then in other communities, I'm aware of how severe the shelter structure and physical plant is in some parts of the country where there's only open space and shared bathrooms. And in those in those environments, I would really be pushing on public health and the healthcare sector to be saying that if we can't achieve a minimum standard for isolation for this individual in the shelter system, public health and the healthcare sector is going to have to devise a solution. So this is really it's not jurisdictionally specific, it's contextual to the individual community.
Great, thank you. A lot of shelters and other day centers will have meal service. What do you think about, one question from Mark Adams talks about, what do you have recommendations for meal service for 80+ people? I know Mark won't be alone in his facility and wondering about what they should be doing about their meal services. Any thoughts?
Absolutely. I want the entire community to know about this, because when we get around to the other end of this COVID pandemic and it is time to write the equivalent of the Naylor report that came out after SARS, where it's the report on how we manage this, I want everybody to remember this. Before a single patient in Canada had serious medical complications from COVID, before there was a single person admitted to hospital, a single person in ICU, there were some positive cases. But before anyone had had a medical impact from COVID, there were people experiencing homelessness who couldn't find a place to sleep and couldn't get a hot lunch. And so our most vulnerable had health impacts before the virus even got here in any meaningful way. Remember that. You will be consulted on it. Make sure it appears in those reports later on. I know that the drop-ins that are volunteer run, have no PPE, have no medical support, are closing across the country, and it's affecting our clients. I would push those facilities to make food, but alter the model. Where it's possible, now is the time to give out bagged lunches and encourage people to head back to the park, not to come inside. And I would never say that under any other circumstance. I would never say that we might protect homeless people out of doors. But the threat of the outdoors right now might be worse than the threat of the large gatherings for many people. So the idea is, let's identify those high-risk individuals, make sure they're protected, make sure that they're in appropriate facilities, while knowing that some of our more robust individuals in the face of COVID might be having their lunch in the park right now rather than in the church basement. Because gatherings of 80 people and 200 people, as we're seeing, are downright lethal right now.
So question about how can non-medical staff identify who's at highest risk? Yeah.
So I believe that a very simple set of questions for an individual based on the data that we have from China and Italy can really identify people who are at highest risk. Certainly anybody who has had a serious hospital admission And by serious, I mean that I know that a huge portion of our population spends a night or two in hospital on quite a regular basis. That's not what I'm referring to. I mean, somebody who's had an ICU admission or something like that recently should certainly be in that category. Anybody who needs help with their activities of daily living, toileting, transfers, eating, anything like that is automatically high risk. Anybody who has an active respiratory problem, if they take puffers on a daily basis or wheeze at baseline, they are high risk. And I know that 30% of our population has a cough at any given time. That's not what I'm referring to. I think for those of us who have, groups of people that we know so well, certain people jump out in that group. And they're not only people who have a dry cough now and then, who have real conditions. And then asking people a couple of simple questions. Do you take medications for your heart or lungs? Have you been admitted to hospital, as I mentioned? And then knowing full well that from a physical perspective, people who experience homelessness are older than their stated age. I would say that people over 55 would get a point in that direction as well. And so I'm not saying everyone over 55, but think about these collection of things. People who can't walk down the street without getting short of breath or up a flight of stairs, or people who have been admitted to hospital recently. Pluck them out of your community, identify them, and find ways to protect them.
Good. So another question is from Cheryl Topham. If we were lucky enough to find extra space for the highest risk homeless, staffing will become a problem. The shelter is understaffed as it is, and how would this work? And I might be tempted to take a stab at this, in particular saying this is again an issue for public health, right? This is where those municipal emergency plans come in. This is where the support from public health would be important, because they can or should be able to find some other staffing to support. I also understand from the announcement this morning that the federal funding, when it comes to community, can be used for staffing. And one other question is about how will that money get there? I think that's going through the existing reaching home infrastructure through the community entities. But do you have any thoughts or comments about staffing to Cheryl's point?
Tim, you're absolutely right. There are relief packages that are being rolled out, and I suspect there will be 3 rounds through this of relief. And the first has really been announced, certainly in Ontario at the provincial level and federally. There's another way to think about this staffing shortage, which is that if I take the 600-bed facility that I work in clinically, which really does have a lot of high-risk individuals, but quite a mixture, I would not advocate for trying to move more high-risk people into that facility. I would advocate for opening emergency shelters that are going to be less well-resourced, less well-staffed, and have open spaces, which is less optimal. Identifying people who are the lowest risk in those facilities and moving them into the new spaces. So I think that many of our highest risk people, there is a facility or there is a place in our communities where we wish there was enough space for them. And it might actually be about moving the lowest risk people into new space, and not trying to staff up new high risk settings, but actually maintaining the staff in our existing high risk settings and moving the lowest risk people into the new space so that there's more space in the high risk places or in the most served places. So what does that mean in terms of staffing? It means open new facilities on an emergency basis, and we can do it now, that are staffed with, and there will be some confusion there. Those emergency spaces are always complex to run, but plan to run them for our most well members of the community of people experiencing homelessness and move them most well there. from the street and from existing shelters to create space for those super high risk people.
So we're getting questions through our through the chat and through and through the Q&A. So I'm going to do my best to get them all. I tell you right now, I'm not going to get them all, but we are developing an FAQ, and we'll do our best to get answers for all of these questions, and we'll have another webinar. But Kathy Crow has a few questions, but one is anyone screening on entrance to shelters and drop-ins yet? In Toronto, the screening tool will be available maybe today, she says, with a question mark. Street Nurses Network wants nurses on site to do the screening. The city is saying it'll be existing shelter staff. Given your point around assessing changing cough, shortness of breath, what is your opinion?
Yeah, so Kathy, you're one of those people where I say I'm honored to be able to connect here. Thank you for these questions. You're right. The screening guidance should be out from SSHA. That's our shelter administration here in Toronto, and from Toronto Public Health today, unless there are any other changes. And a major change came out from the province today on really moving away from travel-based assessments. This is a real challenge in developing guidance right now. No sooner do you develop it and try to push it out across a large administration than it's wrong. And so that's a real challenge, and sometimes leads to the perception of delays when really what it is that no one can keep up. But yeah, the plan is to have that guidance out today. I don't work for that administration, but they have asked for our input. And I think it will be very helpful at shelters to be instituting some form of screening with a real emphasis on maintaining an inviting and sheltered approach to this. So people who decline screening should not be, I don't think should be excluded from shelters under any circumstance. Instead, they should be brought in and approached when they're ready around their symptoms, or if they're exhibiting overwhelming and obvious symptoms, to coax them to healthcare environments. But certainly, I don't believe that screening should be a necessary requirement to get into shelters. I'm also very much aware that in many of our shelters across Canada, especially with some of our highest risk individuals, they don't leave the shelter. It's very, in some ways for them, it's like a long-term care facility. They stick around most of the time. They're there for multiple days. And so we need to be screening inside the shelter also, approaching people who are there and asking whether they have symptoms, because the front doors won't cut it. These processes are evolving really, really fast, and figuring out the place of screening in the context of a mitigation strategy gets more complex, which is why I'm interested in that parallel project of screening not just for symptoms, but screening for risk, so that we can say, you know, you seem well, but you're really high risk around this. Let's see whether we can get you into a place with a little more protection.
Great. Jerry Blenick, and again, I apologize, I'm going to mangle names, but in terms of containment considerations for staffing, do you recommend having, or would you recommend having a proportion of staff working out of shelter so that as staff need to self-isolate, there are other staff who are not a source of infection? We've been directed by public health to keep all staff working to support our clients out of community to prepare for potential isolation and support reduction use of unnecessary visits to ER.
So I don't believe that that form of staff cohorting is necessary, where we sort of have groups of staff working together so as to not cross contaminate, for lack of a better term, the staff against one another. But here's what I would say. I think every organization needs to do the extremely painful but essential work of drawing a diagram of what they would do if they had a 20% and a 50% reduction in staff. And doing a tabletop exercise on that. And I say that knowing full well that it's no fun. And our first reaction to it is absolutely all of our services are essential. They're underfunded and understaffed. So that's the starting point. And now let's drop it by 20% and have it and decide what we're running and what we're not. And that's part of the reason why I really go to this risk stratification strategy, so that at least we know which members of the community that we serve is likely to survive that type of challenge.
Mm-hmm. At the heart of some of these challenges is access to PPE supplies due to the demand. Any thoughts on how to find more PPE, where to get it from, how they would access it, or what are they going to do if they don't have it?
This is a place first to be pushing public health directly, assertively, and without reservation that again, practicing or working with, if one is healthy and asymptomatic in an environment of people with active disease, if there is a true mitigation strategy where this is moving through our shelters, is below a minimum standard and unacceptable, so that the supply management issues that are being attended to centrally in Canada can be addressed. And to do it without suggesting that providers will show up to work without adequate PPE. And I can't sit here with a straight face and suggest that any provider should be compelled or feel that they must come to work without appropriate protections. And I know that my greater risk with an audience like this is that most people will. They're just so committed to the care of this population, but we're our own worst enemy on that front. And so tell public health how badly PPE is needed, make sure it's articulated in a way that is direct, and as part of that exercise of thinking about 20% human resources loss, think about, if you have a limited supply of PPE, which services should remain open. Knowing that some staff will come even though they shouldn't, I know that, and some staff will want PPE, and what we don't want is just trying to keep all services open while pushing staff to work without the necessary protections. I think it's better to actually have done the painful exercise of looking at a piece of paper and listing in order of priority the services that we run. Where do we want staff if they're available and they have PPE?
Mm-hmm. So do you have any link or information on where people can find information on how to teach their LPNs or staff on how to test for COVID-19? How
to actually do the swab, or
I guess so, yeah. I think that's the question, yeah.
So I'm not aware of a jurisdiction that has done that or taken it out into the community. All of the nurses that, or I shouldn't say all, but many of the nurses that we work with and who support our activities will be familiar with this procedure. It really is taking a Q-tip that's about 2 inches long and just sticking it into the nose, and you put it in there until it feels like you're going to sneeze really badly, and sometimes you do sneeze, and you twist it around and then you take it out. It's very, very straightforward. You can find a YouTube video on how to do it. The challenge is getting permission to do it, not being able to do it right. And so if you have health professionals and they have the resources and the drive and permission from public health to do it, we can enable others through medical directives to do this testing. But I would emphasize that we need to know why we're doing that. How does it contribute to mitigation? Not just, are we interested in whether the person has COVID-19?
Right.
I'm seeing lots of questions about harm reduction. And I would like to say something around that. I think it's absolutely critical and particularly challenging. I don't know about every province. I think that with time we are likely to see a national declaration of a state of emergency. We do not have that yet, but we do in some provinces. For those running sites with federal exemptions for supervised consumption, there is a specific piece of the legislation and even a form for emergency extension of that exemption. And if only as a effort of using that piece of the legislation under appropriate times and considering what it's for, I would encourage people to look at where else under this sort of circumstance emergency access to supervised use might be necessary, and refer to that form. It really is just a form to fill out with a brief explanation, and I think that they will move through. So I think it's important to attend to that. But now is also a time to be reaching out to the, how can I put this? Reaching out to the providers who had a rich history of harm reduction and safe supply and supervised consumption even before there was legislation to support them, and seeing how they can support the undertaking. Perhaps that's a good way to put it.
Okay, let me just look here. Are there considerations that outreach workers and outreach-based care teams should be aware of to effectively support triage? I think we've talked about some of that. Any other thoughts?
Effectively support triage. This epidemic will evolve, and I will say that we will start to see people who are not, where we're not just curious whether they have COVID, but whether we're curious whether they need healthcare to support them through this. And so that's going to start. We're going to start seeing people with more severe illness, and we have a rich tradition in our sector of supporting individuals and helping people to get healthcare. But I also think that a part of that triage and a part of this this arc is going to be preparing ourselves for some losses and the need for some healing circles and for self-care and care for one another on an emotional level. And I see that as part of triage in a sense, to be reaching out to our colleagues and to our communities. People who experience homelessness, as we all know, are autonomous adults that are part of our community. And talking to people about how they're feeling about this and their fears, I think is a very important part of the triage and community outreach process.
Okay. Do you have any recommendations for Housing First stability programs working with housed and homeless individuals? For example, Jesse, sorry, I'm just looking up your name, Jesse. Jesse has said that they've stopped transporting participants who are working on food security for housed individuals, many of whom are quite vulnerable.
Yeah. I will confess that under the present circumstances, although I generally take a very broad definition of homelessness and underhoused, I have been focusing my attention on the shelter and unsheltered population. That is not to suggest that there aren't tremendous risks outside of there. I just have not built strategy in that space. Other than being able to say, I agree that they're tremendously vulnerable and that there will be more people needing shelter services because of this crisis. And that's, again, going back to this overarching theme, the fundamental tragedy here is the starting point, the shelter system, the housing fragility and brittleness in Canada, and the consequences that come from it, not the decisions that we have to make within that context.
If there are more people that are not in shelter or maybe rough sleeping or in encampments, do you have any thoughts on how to provide care and support testing to those people?
Yes, so I think street outreach for testing in that group who has a change in their symptoms, so change in cough, change in shortness of breath, fever, is a really good idea. Anybody who is doing that kind of outreach can do that, especially if there's a nurse on the team and you need permission from public health to do the NP swabs. It'd be nice to identify COVID-19 in street encampments early. And then this is where the risk stratification comes in. I fundamentally believe that anybody who lives in an encampment who wants to be sheltered should be allowed to be sheltered, and that we should not be evicting encampments. Fundamentally believe in that. Right now, what I think we should be doing, while also not evicting encampments, we should not be doing that, is identifying the people who are at highest risk from a cardiorespiratory perspective in encampments and giving them a special opportunity to be in a space where they, again, have a bit of a moat around them.
Mm-hmm.
Yeah.
Sorry, that ties into your point here. One, Sarah Lovett is working in an 80-person shelter, and they recently stopped doing new intakes. Is that a good idea? Or taking new people in?
So again, depends on the type of shelter and the type of resources there. But this is the very hard decisions that come under this circumstance. I think we will soon find ourselves in a position where it would be appropriate to bring in people at particularly high risk due to their cardiorespiratory function. And if there are other emergency shelters being created or less optimal, like if this is a well put together 80-bed shelter, maybe it has individual rooms, I don't know, having the highest risk people in there, and if there are people who need to be identified to be moved to a gymnasium style open shelter, that should be people with stronger lungs and hearts. Mm-hmm. And so it's not just should we be taking people in, it's who should we be taking in, and should there be people who are moved elsewhere. And I say that only in the, like I'm speaking to you from inside a hospital where I came from a meeting earlier today where ventilator allocation was on the agenda. ICU ventilator allocation. And so I know it's hard in our sector to talk about potentially allocating somebody to the street in order to bring somebody in who's super high risk. That is not how my brain usually operates. But when our friends and colleagues are simultaneously doing ventilator allocation, it might be important to have real conversations about if we have people on the street, who do we have on the street?
Mm-hmm. I think a more important conversation, or a parallel conversation, is how do we make sure that we can create enough shelter, enough isolation, enough quarantine, that none of that is necessary, right?
I absolutely agree. And so we can open emergency shelters, and our system in Canada has the capacity. But our usual approach around emergency shelters is to keep everybody where they are. And if there are additional people who are outside, move them to emergency shelters. Mm-hmm. And we're at a very interesting moment on whether we should be opening emergency shelters and putting a little more work into figuring out who and where. And that's just a little different, but I'm totally with you. With the will and the resources, we have enough space to keep everybody who wishes to be inside.
Yes. Now, I guess I want a slightly more tactical question here, but how do shelters estimate the amount of PPE needed? Is it like based on average number of clients served, or Sarah Munier is wondering how we'd be able to ask specifically for quantities of gloves, gowns, masks, goggles, etc., rather than we need PPE?
Yeah. Again, there's no model for this. Like there's no, because it's not one set per visit like it is in a health care environment. What we do know is that masks and goggles, or masks and face shields, can be worn until they are the mask feels moist, or the goggles or face shield is coughed upon or sneezed upon. And gowns can be worn until they come in contact with anybody. Gloves should be changed constantly, or with any interaction. And so I don't have a formula for you for estimating within a shelter. What might be useful if you have some PPE is to count over a day or two how much you go through. wearing it for most interactions, and use that to extrapolate out. But I don't have a resource, I'm sorry.
Okay. So I think we've been through, I think we are being through quite a few of our questions. I don't think we got all of them, but I know our time is coming to an end. But as I mentioned before, we're going to collect all of these questions, try and distill some into a Q&A or an FAQ document that we'll post on a website. I want to just share my screen to show you the website in particular that we're referring to. This is the Canadian Network for the Health and Housing of People Experiencing Homelessness, cnh3.ca. There's a resource page there where we are collecting and putting together information. This is changing almost daily. We have a bunch of stuff that has been added. The response framework that Aaron was referring to earlier is this document here that you'll see on your screen. We'll be posting a recording of this webinar here, as well as an FAQ. I'm just going to check really quickly to make sure we haven't missed any new questions. I don't see any unless I'm looking at this stupid thing backwards, which is entirely possible. Yes, so let me just double check last couple of questions, and then I'll see, Aaron, if you have any closing comments. Yeah, so Sarah was asking about the estimates. So if anybody has thoughts on how they're estimating the amount of PPE, that would be very helpful. And feel free to send that, any other questions or comments, to info@caeh.ca. Email again, info@caeh.ca. Please send your resources, tips, tricks, other questions to that email address, and we'll be including them, and we'll try and cover some of this in our next webinar as well. One question from Adriana is asking, homeless youth present different challenges compared to adults. We're planning to put youth who require isolation in motels. However, I'm concerned about having young people stay on their own without support. What strategies are there for working specifically with youth?
So the model for isolation-specific shelter spaces, motels, and otherwise that we've developed is a supported one with 24-hour nursing on site, which does help with some of that. The needs for youth are tremendously variable depending on age and otherwise. I certainly wouldn't advocate for the splitting of families or the splitting of supportive relationships in order to achieve isolation. Even in people who are housed and have their own homes, the guidelines and guidance for isolation isn't for the person. Like if I were to have COVID or be under investigation, it's not required that I am isolated in the common sense from my family for that entire time. I'm allowed to be in my home where my family is. And to interact with them just using certain precautions. And so many of those youth have core relationships, so the things that keep them able to do the things that they do, and finding ways to achieve isolation in a way that supports and maintains those relationships is the most critical. Here's an important thing from when I was working in public health proper. The success of isolation and quarantine it's not a matter of how thick the bars are and how effectively the room is built. That's a high security prison issue. Isolation is achieved because you get the person the things that they need to be perfectly happy hanging around the room or their house for a couple of days. That's what makes isolation work, is just setting the person up so that it's a pretty nice retreat for a couple of days. And most people are willing to do that. And the beautiful thing about public health is that most people want to protect their community, and they understand that purpose. They're a little afraid around COVID too, and they understand that purpose. So if they're supported to do it, they can do it. That's challenging in our population. I saw a question come up on the chat just now about people who use drugs and need to be able to get to their dealer. This is what I mean when I say safe supply is so important. But somebody who has access to their drugs and understands this challenge and is able to use them in their isolation facility may be perfectly happy to stay there. Somebody who has permission for their dealer to come and set them up in that room may be willing to stay there. And so we need to have those conversations, be bold and upfront about them. And most anybody can achieve that if we support them. Youth, people who use drugs, people with other mental health needs, a variety of issues. It's doable, requires creativity. In a crisis, it's the ideas that are lying around that really make things work. And so if safe supply is lying around, now's the time to pick it up.
I guess this is partly answered in your earlier comment, but how do you help support clients who don't want to self-isolate or refuse, and they may have tested positive or are displaying symptoms?
I'm not familiar with the legislation from province to province, but that's something that should be discussed with your local public health unit. There are strategies. Those strategies are always balanced against health risks and hazards to the public, and we should be aware that COVID-19 is not Ebola. This is not a tremendously lethal condition where somebody is likely to be to have particularly coercive means used to keep them in their isolation. It's just not dangerous enough, and it's likely to flow through our community. So I do not expect, although I'm not aware of any cases where this has happened or been actually explored right now, but I do not expect public health to be using its most coercive powers to require isolation from anybody under this circumstance. It just doesn't make sense to lock somebody up for a condition that is going to flow through the community no matter what we do.
Awesome. Well, I'll see. Aaron, do you have any sort of closing thoughts you would like to make? Again, I think we could stay here all day and go through a lot of questions. But
my only closing thought is to reiterate that if it comes across that I'm raising ideas that are challenging, that really push some of our baseline assumptions, that even feel a little scary, I share those sentiments. This doesn't come from a place of feeling brash or having a willingness to take on things just because they might be exciting. That's not how I feel at all. I raise these uncomfortable ideas because I think we might need to be a tad more aggressive and more creative to really save lives under this unique and surprising threat. Like we didn't fully see this coming, and that is going to require ideas that we didn't really see coming either.
That is a very good way to close things off. Thank you, Dr. Orkin, for your wisdom. I know it's been very helpful. A number of people who have made comments have found your comments very helpful in putting together their thoughts. So you know that the Canadian Alliance and CNH3, the Canadian Network for Health and Housing of People Experiencing Homelessness, are continuing to work and be on top of federal officials to try and get the public health direction. You saw some resources coming to community from the federal government today. That's a direct result of your feedback and ongoing communication with us through CNH3 and through the Alliance, and our ability to hear what's happening on the ground and the things that you need and convey those needs to the federal government. And we will continue to do so, and we'll continue to post resources. And as Aaron said, in these crises, a lot of the answers, many of the answers are in things that are lying around, and there's a lot of wisdom with the people that are on this call, sharing your resources, sharing your protocols, sharing your plans, sharing your estimates of how to calculate PPE, all of that stuff is very important, and we're developing a bank of those resources. So thank you, everyone. Thank you very much. I got to say, from the bottom of my heart, for all of the work that you're doing on the ground. I know it's very risky. Thank you for the work that you're doing every day, and the rest of us sort of stand with you, and we'll do everything we can to help you. We have another webinar same time next Wednesday. Feel free to tune in then, or again, email info@caeh.ca if we can be of assistance. Thank you all very much. Stay well, take care of yourselves. We'll talk to you soon. Thank you. Thank you, Aaron.